Welcome everyone to the third in our evening MPX webinar series. This is a partnership between the STD HIV Prevention Training Center at Johns Hopkins and the Maryland Department of Health. I'm Barbara Wilgus. I am the program administrator for the Prevention Training Center. I'm just going to go into a little bit of housekeeping here. Your Zoom registration to enter the webinar, so your name and email that you use to get here, that's your sign-in sheet for the day. This is how we are taking attendance. So if you're using a different Zoom, like a different email for your Zoom link than the one with which you use to register for the course, please email Bambi Hamby with this information. Additionally, if you happen to be watching in a group where all the participants are registered, but you're using one person's computer, also please email Bambi the names of all the other watchers in your group outside of the person's Zoom screen, because for CE credit, each individual participant needs to have registered for the course. This is a webinar format, so you may have noticed that you do not have a camera or a microphone. So therefore, if you have a general comment or a technical question, please enter it in the chat box. And I'm also going to make sure that the chat box is functioning as soon as I finish this welcome. If you have a question for our speaker, please enter it in the Q&A box below. These webinars are being recorded, as you may have noticed. Recordings are accessible via the Maryland Department of Health MPX webpage under the section Information for Clinicians. That and many more resources are available at their website, which is health.maryland.gov/monkeypox. So, CE credit, you must have registered for this course via the National Network of Prevention Training Centers. So you must be registered. You must be here attending the live and interactive viewing of the course. And again, we're taking attendance as previously noted. Unfortunately, if you're watching this as an archived recording on the MDH website, it does not qualify for CE. Once we have marked those who have attended completed, we will email instructions for those who have attended on how to get your CE credits following the course completion. This is going to go to the email address with which you registered for the course itself. So again, if you're using a different email to be here, just make sure we are aware of that. You'll have 30 days from today to go to the CDC website and get your CE certificate. And again, this is only for the live and interactive viewing of this webinar. So a few words about the National Network of Prevention Training Centers. You'll see we in teal, the STD HIV PTC at Hopkins, are only one of 8 regional training centers. So if you're hailing from a different state outside of Maryland, look and see if you happen to have another prevention training center that is your primary one. We provide training and technical assistance to clinicians in our catchment areas, and we're happy to help and refer to other PTCs if need be. But this is the map of the NNPTC. Additionally, some of our national offerings, the STD-CCN or the STD Clinical Consultation Network offers free expert clinical consultation for clinicians having questions in any field of STIs, including MPX. So if you have a question or have a question or a consult that you need, you go to stdccn.org and submit their information, and it will be routed to a subject matter expert in your area with response within 1 to 5 business days, depending on the urgency that you set. So this is an amazing resource available to all clinicians through our NNPTC. Additionally, if you want more continuing education, the National STD Curriculum is available at www.std.uw.edu. It has been updated for the 2021 STI treatment guidelines. It's a free, up-to-date educational website with self-study, on-demand, quick reference lessons, question bank topics, a fabulous podcast, which I highly recommend. And it is a group learning tool that you can use to assign units or track people's progress in completing their CE as well. So I definitely recommend checking that out. I also want to mention some resources that are available at the Maryland Department of Health website specific to MPX. So here is what the website looks like when you get there. Information for clinicians will have many resources, but including these recordings, and additionally some resources for patient handouts, things like that. And also, I think this is my next slide. Yes, this is actually where patients sign up for the MPX vaccine pre-registration. So for sure, visit our the Maryland Department of Health's website to get that critical information, because that is the best way in Maryland to sign up to receive the MPX vaccine. And then finally, from the Centers for Disease Control, the STI treatment guidelines are now available on a mobile app, which is available for iPhone and Android devices. You can, once you get the slides, you can screenshot the little code thingamabob, or you can go to CDC's website to download the app. There are lots more resources available through the STI treatment guideline app now, including a direct link to STD-CCN. So definitely recommend that, and hope that you will avail yourself of all these amazing resources available to you. And now I'm going to stop sharing and start introducing our speaker, who is Dr. Elizabeth Gilliams. Dr. Gilliams is the medical director for STD services at Baltimore City Health Department Sexual Health and Wellness Clinics. And in this role, established early leadership, like super early leadership in the MPX outbreak response for Baltimore City and Maryland as a whole. Her clinical protocols were adopted by many programs seeking to effectively establish testing and treating for MPX. Dr. Gilliams has gained clinical experience in treatment of HIV and STIs during her residency at Emory University and out in Atlanta, Georgia, and infectious diseases fellowship at University of Washington in Seattle, Washington. She has served as an HIV primary care provider and STI clinician during her training, and she is the medical director for STI services at the sexual health clinics at Baltimore City Health Department since 2018. And she is going to be discussing tonight the nuts and bolts of testing for MPX. And I see your screen. Yep, there we go. All right, take it away.
All right, thank you so much, Barbara. And thank you everyone who's here on an evening taking some time, their personal time to learn about monkeypox, or MPX, as I'll call it, throughout the course of today. But really what we're going to focus on today is nuts and bolts of testing. What do you need to prepare your space and yourself for testing, what supplies might be helpful, and how to sort of like make this come from an idea into something physical that you will be ready and prepared for. So I'm happy to also pause for questions, Barbara, if they come through in the chat or in the Q&A area, if it seems appropriate. So just a few words on disclosure and conflict of interest. I have no conflicts of interest, but some images and companies described in this presentation are for demonstration purposes only. It's not an endorsement of any particular product or service. I just put them in there because they're part of the landscape of commercial laboratories. And so I would be remiss if I did not mention those a little bit more, or just include them in what we're talking about today. So my outline for today, we're going to talk a little bit about planning for success, what planning steps, space, what things would you need to bring together, PPE, testing supplies, and I'll go into detail. We'll have pictures, specimen collection techniques, and then some other words on what other testing might you consider beyond just MPX testing to have this be a comprehensive sexual health encounter for this patient who may be in front of you. And then a few words on infection control and cleaning. So first up, we're going to get into preparing your space and patient arrival. And so are you and your space ready for testing? The key thing would be, do you have a potential way that might help you have a good triage process for your patients, or identify people who could be potentially having symptoms of MPX? And so one way that this may happen for you is, if your clinic or practice or wherever you are is still doing some sort of COVID screen, that may still be happening. Maybe that could be rolled into that set of questions. This may help you, sort of triage, okay, this patient, instead of having them sit in the waiting room, maybe we'll have them directed, right away back into a patient room. This will help also for you to potentially give the patient a heads up. So if you know that they're coming in and, maybe some patients will say, I am concerned about MPX, this is what I'm coming in for, others may not. But either way, it may be helpful to let this patient know your visit might be a little bit different. You may not be sitting in the waiting room. You may see people dressed up in all kinds of PPE garb. And I learned this from a patient who told me, actually, this was quite surprising for them. So I think it's really helpful to have that, moment to say, okay, this is what you're telling me, just so you know, this is why we're doing this. And so it helps you to manage expectations for what a patient's visit may be like. If you also have an opportunity to triage or screen ahead of time, if someone's making an appointment and there's a possibility of MPX, you can also give them the counseling to please come and wear a mask and to cover the skin or areas that are affected with this rash, to minimize any potential transmission. And so this will again perhaps help you to minimize time and shared waiting spaces, meeting them directly when they arrive, getting them into a room if that's feasible. And maybe help you, to identify, a way that someone could escort the patient to a room quickly. This may not be feasible in every setting, but just helps, to jog your thinking of how could we potentially, detect this early on in the patient's visit process. So I just like to start there. And so some sample triage questions, I'm just throwing this out here. You can use whatever you feel is useful in your space. This is what we've been leaning on in our space, because at the sexual health clinics, that's kind of what we do. And we have seen a number of cases, even though that's kind of trailed off over the past weeks. But what we still continue to use is, are you concerned you might have monkeypox or were exposed to monkeypox? Or are you calling for an appointment because of a new rash, bumps, or skin concern? And someone may not be aware that specifically what they're experiencing is monkeypox. Maybe you just want to screen by this kind of, more broad term. It's up to you what you think is feasible in your space. But any of these questions that initiates sort of MPX precautions, further assessment, and additional triage. So I think the next thing is, okay, we've thought about how we're going to identify patients, is where are we physically going to be doing this testing in your clinic space, in your practice? And so first thing is patient placement. Ideally, this is something that, the patient will be in a single room where they can close the door, and as a private space, but also as, not, out in the open. I want to note that special air handling is not required. So it is not required for this to be a negative pressure room. I know that was a concern early on in this outbreak, but that's not felt to be a requirement for testing. Another piece is you may want to have a dedicated bathroom for this patient if they should need to go, because you will want to try to avoid any, someone using the restroom and then another patient following them. So it may be helpful if you have either a dedicated restroom, that's attached to it, or just right close to it. That could help with reducing potential exposures. So what I like to think of, and what I've advised folks, is think about what's feasible for you. If you have this triage process, if you're expecting someone coming in, you may have a dedicated room and just put that person right in that room when they arrive. And that room could be stocked with all the supplies and things that you need for effective and testing and PPE and all of that. But if you have less ability to triage or lower volume, which is actually, to be very honest, where many of us are going right now, with sort of a lower level of cases, is perhaps just having a more centralized supply location with all the PPE, testing materials, forms, all that. Or have it available and accessible to providers or other staff that need to have access to it, in all of the spaces, so they can access it when they need to in those sort of more rare situations. So a couple of different approaches to consider. And like I just feel like as a clinician, this does sometimes feel like your life, but your plan is you're going to get from A to B, really smooth sailing. But sometimes reality, there are a few bumps. And sometimes MPX testing, it is not expected. You may end up in that, sort of moat on a boat in this picture, and you're like, whoa, what's going on? But hopefully this set of, series will help walk you through and help allay some, sort of confusion and allay some, planning steps that, you can put into action and feel prepared. And you can definitely do this. And I will also say patients will appreciate not having to, go to the ends of the earth to be able to get all the care that they need in one place. So I think that's another really important piece, is to be able to meet the patient where they are, to be able to get the testing that they need with you right then, if you have the capacity to do that. So a few words about PPE, something that I think that has been actually a really positive thing from COVID is that many of us are now very familiar with PPE and have access to quite a bit of this. Maybe less so as, things are kind of changing, but I think this is something that, fortunately, many of us have, recent attention to. So for a testing encounter for MPX, what is recommended is wearing a gown, gloves, and eye protection, being either a face shield or goggles, and then also an N95 or other NIOSH approved particulate respirator. And so those are the basics. I also like to just spend a moment, reminding donning and doffing is also quite important. And when you're planning your space of where you're going to be with your patient, you want to make sure you have space for appropriate donning and doffing. I like to share this handout from the CDC, which you can, look online, find it, but it helps kind of walk through the appropriate steps of, okay, first gown and gloves taking off, and then your goggles and face shield, and then your mask, and then hand hygiene. What I also like to recommend is also making sure you have a place where you can don and doff particular items like, your gown, your gloves, your face shield right in the room while keeping a mask on. And then right out of the room, you can change out that mask, put on a surgical mask, and kind of carry on with what else you need to do. So making sure you have appropriate trash cans and all that may be just obvious for everyone, but maybe some clinical practices do not have not previously done a lot of this. We had not prior to MPX. So this was definitely an adjustment for us. I also want to note, when taking off the gowns, it is recommended to avoid shaking and aerating gowns because of the potential for aerosolizing particles on the gown. So again, that's just another teaching point, to make sure you and your staff are being as safe as possible. Okay, so who can be tested for MPX? You've talked with a patient, we've talked a lot about some patients with symptoms, but, really want to zoom in who and how we're doing this testing and what we're going to focus on. So very clearly, folks with skin or mucosal lesions, testing is directed at these folks, and the testing that is done is directed at direct swabbing of the lesion. So you got a swab, you're putting it onto the lesion. And the testing that's done is PCR detection, very much like for COVID testing. I'll also say serology or antibody blood testing is also possible, but not very broadly available. IgM antibodies can become or are present at 4 to 45 days after presence of rash. So it may not be it's really not intended to be the main diagnostic test for monkeypox. And again, it's not broadly available in commercial, or even potentially other academic labs may be possible. It is possible through the CDC. And I could imagine this being a situation where you've tested someone with a swab, and for whatever reason, you have a high index of suspicion that they had MPX, but the testing is coming back negative. This may be a way to kind of, after the fact, confirm the situation, But by and large, the main testing that will get you the results that you need quickly will be the PCR swab tests. And that's the main thrust of what we're going to talk about today. But what about asymptomatic people or people who have been exposed? And so this group of folks, there is not really great options. They're not great options for early detection. We don't know enough information about really what can be detected in people who potentially are pre-symptomatic or asymptomatic. And again, there are serology tests that are available either through finger stick or routine blood testing, or even lateral flow tests, kind of like COVID tests that can detect IgM. But this can also be detected in vaccinated folks, and again, is not very broadly available. Again, that CDC option does require consultation before, and if that were a case that you would want to pursue, definitely reach out to the CCN or your other infectious disease colleagues for support. But I think testing of asymptomatic folks is not really ready for prime time. There is a potential, and there is, a body of research that's building that perhaps mucosal surfaces of people who are asymptomatic or pre-symptomatic, especially rectal tissue, may detect virus when they're asymptomatic, but at this moment is not really ready for diagnostic prime time. So bottom line, we're looking at for folks with symptoms that could be, characteristic for MPX, and those are the folks who we're aiming for testing. And then other folks who have been exposed, of course, self-monitoring, monitoring for any symptoms that do present, but not particularly recommended for testing at this point. I also want to add in too that the CDC has also posted a specific page that's been new in the past, I want to say a couple weeks, about testing of tissue biopsies. And again, this may be more of a rare, very kind of specific situation, but in patients with severe MPX disease, the CDC can review biopsy tissue that has been taken for either complex disease or people who have atypical lesions when you're not totally sure whether the lesion is from MPX or from maybe another secondary infection or other disease process. And they're able to consider taking, specimens from a variety of different sources as listed here. They take, specifically formalin fixed paraffin embedded tissue, but this does require consultation with the CDC as you're preparing and planning to do this. And if this is interesting to you, or you have a situation where this may be needed, you're going to refer to the CDC website here. But again, probably the first line is going to be doing the swab test first, most likely. So we've talked it up, specimen collection with a swab. Let's get into it. I also want to put a shout out to some CDC materials that can help be a good reminder and handout for yourself or colleagues that are at this website that can help walk you through step-by-step technique and other thoughts around testing. So I definitely would recommend looking at these if you want just a handy handout to have it, or a resource to provide for your practice. So before you get into collection, of course, you're going to want to do a very thorough skin examination. And this will help you to get a good picture of what is the distribution of lesions. Are there lesions in multiple phases? Are there some that are, pustular, some that are crusted? Where is the most anatomically easy specimen to get to, or where are the lesions that look most characteristic? And this exam will help you to point, okay, this lesion these two, look the most characteristic. These are going to be the two that I'm going to perhaps target for collection. And so that's kind of how I approach the skin exam. And of course, a skin exam, if the patient is having perhaps rectal or proctitis symptoms, that needs to be included. Genital exam as well. And I'm not saying that a genital lesion is perhaps more going to yield a better specimen than maybe another body site lesion, but I would just go after what appears to be the most characteristic and easily accessible as your avenue for testing. So what supplies will you need? again, will depend on your laboratory that you'll be sending specimens. And this is definitely homework you're going to want to do to have available to you. But in general, broad terms, it may include, and I'll show some pictures later, a dry swab, which essentially is a swab that has no liquid in the container. May also include a swab that's in viral or universal transport media, and you may be familiar with those. It's generally a swab that you put into a tube that has either a red cap with some like pink liquid. That's generally your viral transport media. You may also have kits or supplies where you could consider having a sterile container to put a crust or a scab from that is overlying a lesion. And you may also consider using some disposable tweezers to help do that. But for the most part, I would say many folks have done pretty well with just the swab in either a dry swab or the viral transport media in most practice. And of course, you're going to want some biohazard zipper bags to package everything up, the requisition or the order form that you're using, patient labels, and of course, then your shipping containers or packaging, dependent on what laboratory you're using. Getting into the technique, what the CDC recommends is that you actually will not want to clean the lesion with alcohol or other disinfectant before swabbing the actual lesion, because this may perhaps affect the detection of the virus on the skin. So would avoid that piece of it. And then just for me, if I am considering collecting a scab or a crust, of course, that's laying on top on the lesion. I think about collecting that first if that is something that I'm going to do. And you can use your tweezers or forceps to remove all or part of the crust, put it into your little container, label it as needed. And then in terms of the swab itself, this is the key part. And if you take nothing else from this lecture, this slide and maybe the next one are probably the most important slides. And what I'll say is because the collection technique really does matter. And what your goal is to have enough material on your swab so that you can be able to, so there's stuff to detect. And so what you may have are a couple of different swabs available to you. And typically, and I'm not sure if you can see me on my camera because I'm on full screen, but a lot of the viral transport media kits come with this like rinky-dinky little, floppy swab. This may be familiar to you also from COVID testing, but it's pretty floppy. But essentially what you're going to want to do with your lesion is kind of really get in there with really quite a bit of vigorous rubbing to be able to collect enough specimen. And really, I think you should certainly use the swab that comes with the kit that they tell you to use. But if you have an option, and sometimes your kits come with other swabs, if you can use a swab that's maybe a little more firm than this one, definitely use it. It'll make your life so much easier. And so if you have another swab that's maybe a little more firm, you can get in there and really, I would say, rub it as if you're rubbing something that's really itchy. And that, will be kind of the pressure that you're aiming for. You may see that this lesion will have sort of maybe a pustule. This rubbing may not unroof the lesion, but definitely rubbing on top of the lesion is still effective at collecting enough viral material. And so I would say the priority is the rubbing, not necessarily the unroofing. And I'll talk a little bit more about the dangers of unroofing. If there's lesion fluid present and it is available for you to swab, of course, collect that. Try to collect as much as you can with a swab. And again, this process, it may be mildly uncomfortable for the patient. MPX lesions, I've seen the gamut of it being completely, folks are like, no problem, this doesn't bother me, to being quite tender. So know that and prepare yourself and the patient this may be uncomfortable. And again, once you've done your swabbing, put it into your appropriate tube. And then this being the second most important slide of this presentation being unroofing or lancing pustular lesions, not required for specimen collection. Solely just rubbing on top of the lesion vigorously can be enough. And the reason why is that unroofing lesion, especially with a sharp, is a risk. And there have been now multiple cases of healthcare workers who've had needle or sharp sticks where they've developed MPX after that exposure. And so this is just one case that was in a nurse who had a finger stick on her thumb, and that progressed and did develop actually other lesions as well outside of that needle stick site. And so definitely there has been, big lettering, lots of, messaging about please don't put yourself at risk for a sharp stick when collecting a specimen. So now you've collected your swabs and you're going forward with, okay, need to put this in storage before it gets picked up. Confirm with your laboratory again what the specimen handling should be, but in general, many of these specimens are recommended to be put in a fridge or in a freezer, usually within 30 to 60 minutes of specimen collection. So I would just check with the laboratory that you're planning to work with. I'm going to walk a little bit through the Maryland Department of Health specimens and kind of the kits that they are able to provide and how they process specimens. You may not be using them, but it is still a resource that's available to providers that they can reach out to. There's a link at the bottom of the slide where you can get guidance on submission as well as, communicate about, transport of the specimen, how to get appropriate kits and all of that. But within their kit, what they include, and I'll have a picture later, is 2 dry swabs and 2 appropriate tubes for those to go into, 2 viral transport media swabs, and then 4 small vials for crust or scabs from the lesions. Often I'll say, very rarely we'll have crust that we'll need, and often we won't need all 4 of them. So I would say have available if it's helpful, but probably not required for most patients who are being tested. The kits also come with, some forceps or tweezers to help with that crust collection, some biohazard bags, and our outer firm cardboard packaging that meets transport criteria for the specimens, and then of course the requisition. And these kits comply with the biological specimens or substances category B packaging for specimens. What I'll specifically note is that all of these specimens done at the MDH laboratory, they do orthopox virus testing as well as VZV testing, but HSV testing is not built into it automatically. They are able to do HSV testing and can do it if the orthopox virus is not detected. So if it's positive, they'll say, yeah, your lesion probably was from orthopox virus. We're not going to contaminate the rest of the lab to just move this around. But if your orthopox virus testing was negative, they can move on to doing HSV testing. You just have to provide the appropriate requisition with that. So getting into the kit, what does it look like? All of the bits and parts, starting at sort of everything that we're looking at the left side, again, with the tubes with the green lids. Those are our dry swab tubes. There are 2 of them. And typically what I recommend, because we have sort of enough to test 2 lesions, we'll start off with maybe a dry swab tube, lesion 1, then do, the viral transport media, the tube with the red lid, and sort of do lesion 1, collect swab 1, collect swab 2, okay, done, packaged, and then go to the second lesion. Okay, now I'm going to do the dry swab, viral transport media swab, get those packaged, and then kind of, package everything together. What else we've got in this kit? Of course, we've got our forceps, we've got the small vials for the crust, and again, that little tube fits into that bigger tube with a lighter green vial. They've packaged it so nicely. We've got our paper requisition, the outer cardboard container, and then some bags for leak-proof packaging. I want to move on next to talk a little bit about LabCorp, and this may not be as fully complete. And if other folks have had experience with LabCorp, please share your experience. But I wanted to mention what also they have available too. What they're able to test is, again, 1 swab with universal transport media or viral transport media. And they say you can submit more than 1 swab, but they do have to be submitted in separate tubes. And it is also possible to do herpes or varicella PCR testing. They recommend storage that's either refrigerated or frozen. And again, their kits generally are like, they have a mix of the floppy swab and the firm swab, and definitely would go for the firm swab if you have that option. I guess another question that I was just, wanted to clarify too was, if you have a patient who has only one lesion, of course, go ahead, just do the one lesion. But again, if you have the option of like testing a couple sites, that gives you a little bit of insurance in case perhaps your technique was not as firm as it could have been on the first lesion, and that becomes negative. And then you have a backup specimen that, you've done, maybe a better, more thorough collection of. So if you have the option to do two, I would recommend that. Then moving on to Quest, again, similarly, they will test on universal transport media or viral transport media. They do not collect dry swabs. And similarly, you can submit multiple swabs, but again, in separate tubes. And this is the tube with the green lid is the tube that they supply the viral transport media. But it seems that they will also accept a variety of different sort of similar viral transport media tubes. Just would check with them on their website. And again, they actually prefer frozen specimens, but they'll also accept refrigerated specimens, and it's probably just a matter of turnaround of how quickly can you get it to the lab. So now that we've sent the specimen, we're gonna be sitting here with bated breath for the results, and wanted to talk about what should we expect to see on that lab report. And so I'll say most testing detects the presence of a virus in the genus Orthopox virus. And of course, Orthopox viruses, it's not just MPX, it also includes variola, which is the virus that causes smallpox. It includes vaccinia, which is the virus that's attenuated and used for smallpox vaccination, camelpox, and a bunch of other environmental pox viruses. But the testing that is done for this particular situation really detects mostly, like, it'll detect that you have orthopox virus present, and it'll probably also offer more specifically that they're detecting an orthopox virus, but it's not variola. And so if you get that result, that is enough to say this is a presumed monkeypox virus that has been detected. And again, the technique for testing is typically RT-PCR. And some labs, they will go the further mile and say, we're doing a specific confirmatory test for monkeypox virus. And Quest does offer that in the resulting process alongside the orthopox virus result. So these may just be a variety of things that you see, but in general, the most common thing I've seen is, non-variant orthopox virus detected, and that is enough to move forward with, talking with a patient, moving forward with counseling, contact tracing, all of that. So we've talked about the testing for MPX. What other testing should be considered during that visit? And of course, from a sexual health lens, we want to consider other STIs that potentially could be present, especially including syphilis. And so when there's presence of, primary syphilis could present, as we see on the picture in the bottom left, as a chancre, and does have some features that are slightly different, but may overlap in the appearance of MPX. Also, disseminated secondary syphilis, which presents typically with the rash on the trunk and the palms and the soles, may share similar characteristics as sort of the early macular MPX rash, but has its characteristics that are different. But definitely would consider, okay, syphilis, should be considered. Herpes as well, would consider having that testing as well. Varicella or chickenpox or zoster, shingles, would also be potentially in the differential depending on the presentation, distribution of the lesions that are present. And then if the person has recent sexual activity exposures, Of course, HIV and gonorrhea and chlamydia are also important to include in sort of comprehensive STI testing. We know that cases of people with MPX have had a history of STIs in the previous several months. And so this is incredibly important to have that comprehensive lens of testing if it is feasible in your setting. And so how to get this done? What we've recommended and what other practices have done is that, to reduce exposure and, travel of the patient through the clinic is that really bring the phlebotomy to the person and have the phlebotomist, trained in all that PPE and appropriate donning and doffing. And then for gonorrhea and chlamydia testing, have available to you the appropriate, swabs for urogenital as well as extragenital testing at, perhaps throat or rectal sites as appropriate. And then, if you have someone who needs urine collection, if it's someone, who has, urethral, who has a penis, and that's the best way to screen them or test them for gonorrhea or chlamydia, you could consider having a disposable urinal in the room. You could also consider doing penile meatal testing if that's a modality or site that's approved by your laboratory. That could also be done and is definitely less invasive than doing a urethral swab. It's much more less invasive, but can also offer decent results. Or, you could go the route of, you have an accessible bathroom and, and you are able to, clean that in a timely manner. And that's how you go about with getting a urine specimen. All ideas, just to say, to have all these supplies available to you. So what other things, we've done our testing, we've done our comprehensive testing. What other things have we found helpful to have in the room? And of course, these could be hard copy or even electronic if your EMR is that advanced. But some patient education materials we found have been really helpful. Some general information about MPX, and then also specifically isolation instructions while patients are waiting for results are very key because the isolation should begin at the time of testing because we don't know what that result will end up being. And so that should be very clear and should be available to provide to the patient. We've also found it helpful to have sort of a kind of brief work excuse note for kind of a short period of time, kind of the duration that we think that the lab will turn around the result. And then, if we need to issue a follow-up work excuse note, we can do that. And then also, if you're a site that's offering tecovirimat or TPOXX treatment for MPX, having that informed consent document. If you're a place that does, the hard copy version, you may want to have that, physically available. And, if the lesions are characteristic enough, you could even consider starting treatment, but that will be kind of a talk later on after mine, I think. So we've done all of our testing, we've had our materials, we're ready to wrap up with cleaning and infection control. And so first things first, I would say involve your institution, your practice, your organization's infection control specialist. We always want to keep them happy. We want to follow the rules. They probably have an SOP somewhere on this. So please reach out to them. And I don't want to contradict anything that they say, but so I've kept it as general as possible. But definitely they are your go-to to make sure that you're following all of your institutional policies. When thinking about waste though, most cases kind of can be discarded with regular red bag or clade to be, for the clade that's to be regular regulated medical waste. But if there's a chance that perhaps your patient has had travel to an area where clade 1, or which was formerly known as Central African's clade, if your patient potentially has had travel to those endemic areas like the DRC, Central African Republic, Cameroon, or Gabon, you may consider pausing, thinking, and managing that waste specifically because it is actually managed, it is recommended to be managed differently and disposed of differently. And so I would say contact your local health department, contact your infection control specialist if there is a concern of potential clade 1 MPX that you're dealing with, and how to deal with disinfection and waste removal. In terms of disinfection, you're going to want to make sure that all the surfaces that have been in touch with the patient has been disinfected. And if you are part of that infection control team, or you're trying to, sort of help support that group, the CDC has offered information about how to find products that are, appropriate for disinfecting MPX virus. And so you're going to want to find one that is emerging viral pathogens claims that is supported by that. And you can find this by going to this website here, and that's on this list of, does my product have a claim that it could, cover emerging viral pathogens. And I'll show you here what this looks like in case this is going to be you doing it. If you have the product in front of you, on its label, it should have the EPA registration number from the product package. You can also just search, it's a very long list if that's what you need to do, or enter in the product name. And then you're going to, request that it's confirmed the product is active against tier 1 viruses. And then this is sort of what the list pops out for you on that website. You're going to look, okay, my product has, quaternary ammonium, and say, yes, is it appropriate for tier 1 viruses? And then that should be something that's appropriate for disinfection for MPX. And a handy tool for just disinfection of other viruses too. So if you need further references around RSV or flu or whatever it may be, this list can also cover that as well. Then, you found your disinfection materials. You're going to want to remove the waste following your patient is departed, from your office or practice. And of course, if there is any laundry that's involved, there is some specific guidance from the CDC about that. I would refer to it on their website if that's something that you are dealing with. But specifically, the CDC has called out trying to avoid sweeping, dusting, vacuuming, anything that would aerosolize particles and potentially be an aerosol risk for transmission. And then a question is, room turnover. When can you use that room again after it's been disinfected? Again, follow your organization's practices and protocols. But what I'll say is that many providers have put into practice that these rooms can be available for immediate use after appropriate decontamination, disinfection. So that, just keep that in the back of your mind if that's something that you're trying to find, what is the community at large doing. And so we've reached the end. I'm happy to take questions right now. Happy to have my email here for a reference in the future. So thank you for your time being here tonight, and happy to take questions.
Okay, so any questions for Dr. Gilliams, please feel free to put them in the Q&A. And as you're thinking and typing, I will start things off by just asking, this is actually a question that I've now asked in 4 different webinars now, which is that kind of in our current part of the bell curve of, the cases seem to be declining, but you'd never know, how would you advise clinics that may already not be seeing that many cases, as far as like keeping supplies on hand? What would be kind of the essential thing that they would want to sort of know that they have a supply of?
Yeah, I think it's a good question. I would say if you will be taking on testing, I do think it's, I can't predict the future. I don't have a crystal ball. But I do think this is something that may be with us for some time. I can't say that it'll go away completely, but I think if you're serving populations that could be most highly impacted by MPX, and I'll say not all cases are, among people who are among those populations, they may be the partners or family members or roommates of people who are affected by her in those populations. And so what I would say is make sure you've got your PPE. And of course, again, another like sort of leftover from COVID is that many of us may still have, easy access to the PPE that you need. Keep up with your N95, fit testing. And then I would say make sure you have the requisitions and probably the swabs and packaging that you need for your testing. And primarily, it seems that many testing laboratories are moving toward just doing the viral transport media. I think that's probably going to be the vast majority of laboratories of what they will accept. But of course, if your arrangement is, something different, work with a different laboratory, be on board with them, keep a few kits on hand. Probably you won't be running through like we were testing like maybe 6 people a day in late July. But, I think having a few of those supplies on hand can be helpful. And the good thing too is that those viral transport media swabs, they're also useful. If you're doing herpes testing, you will have them. If you're doing COVID testing, you will have them. So that I think is, you'll have some of those if those are your situation.
And as far as I'm still looking to see if questions are coming in the Q&A, but in the absence of any coming in, as far as I'm trying to think how to even ask this question. So there will always be a surprise patient, like a person that comes in. I did this to my sister sexual health clinic today. Actually was scheduled someone that I saw got tested for MPX that I didn't schedule as an MPX patient. So there's always a thing that happens where somebody comes and how they describe their symptoms. And then once they come, you watching as the provider may be halfway through an exam and realize, oh my gosh, this could be MPX. What's your reassuring advice for like clinicians in that situation where you kind of start out, in your room, just like a regular old day, and then you need to kind of switch gears and go into MPX testing and PPE and things like that?
Yeah. Well, I will first say, it's a thing that can happen and it can throw us off. Absolutely. Like that's oh my gosh, now this is new. And, you're kind of like, and this is a whole shift in my trajectory of the visit. So that, it can happen. Take it in, take a deep breath. You can do this. And so my reassurance would be that it doesn't appear that there are many healthcare provider transmissions, barring sharps or direct contact with lesions, that it doesn't appear that, at least at this moment, that MPX is easily transmitted without close intimate contact. And so I want to put you at ease in that space. And, even if you're not immediately wearing an N95, I think that probably, more information will come out. But there have been multiple there's been now, I think, an MMWR of cases among healthcare workers in one of the states, I can't remember exactly, who had potential exposures and none ended up developing MPX after that. And so take a deep breath, do what you need to do. I will also just, what I have heard time and time again is that folks will come to us after having had really challenging experiences or being told they can't be tested at other places or maybe have been missed. And so I think there's a lot to be said for, taking that patient in and really meeting their needs when they're coming in, which is so helpful to them.
I have a question. I'm not a clinician, but I know that you said that with the test, you put it in the bags and everything, and then you refrigerate it. I know that some of your tests that you normally do for sexual health have to be refrigerated as well. Do you need to separate these, or it could be used in the same type of refrigerator for specimens?
A good question. So all of your specimens should be going into a dedicated specimen fridge. But during the course of packaging your specimen, the way you will package it is so that the outer specimen containers, so really only the specimen itself and maybe an outside baggie should have ever had any contact in a space with the monkeypox or MPX, potential contamination. And so you will probably want to practice how are you going to safely double bag, changing your gloves, putting it into a clean bag. And so that kit itself should be safe for a courier to pick up, and transport out to the laboratory. So no separate fridge unless you have a particular need to separate them out of your convenience. But they can, coexist in a fridge next to other patient specimens as long as you've done your diligence to package appropriately and not contaminate the outer container.
All right, and I do want to give props for just mentioning the advice to tell the patient what to expect, since it is kind of a whole different process. It might take longer. They might be wearing something different than they were, like the last time you had just your regular old STI screen, things like that, because it's makes the experience a lot less stressful for the most important person, the patient who is the most affected. So props for mentioning that as well, because I think knowing what to expect is 9/10 of what makes a healthcare visit less or more stressful, but less stressful if you know what to expect and you kind of know, well, this is just kind of, whatever. So all right, well, not seeing any other questions, I'm slowly going to start wrapping it up then, unless someone has one to put in the Q&A. And I want to thank Dr. Gilliams for her time, and thank you all for coming. This has been wonderful. This is our last evening webinar for this week, and then we'll conclude our series on Monday at 6 p.m., Monday the 14th. With a in-depth webinar on vaccines. And so thank you all for coming. We hope that you will come to the next one as well. Thank you all for the work that you're doing, for your interest and continued vigilance in this outbreak. Thanks to the Maryland Department of Health for their support as well. And we hope you all have a great evening and a wonderful rest of the week.